All right, let's dive into a topic that, if you're in GI or internal medicine, you absolutely need to know. Gastric Antral Vascular Ectasia, or GAVE. We're going to break down what it is, how to spot it, and why getting this diagnosis right is so crucial for your patients. Let's get into it. So, why are we talking about GAV? Well, let's start with this number, 4%. That might not sound huge, but GAV is responsible for about 4% of all non-variceal upper GI bleeds. That means it's a significant player you're definitely going to see, so knowing what to look for is absolutely key. So, here's our game plan. First, we'll cover the basics. What exactly is GAVE? Then, the fun part, spotting its classic watermelon stomach appearance. After that, and this is super important, we'll cover how to tell it apart from its main look-alike, portal hypertensive gastropathy. From there, we'll talk about the other diseases that tend to go along with GAVE, and we'll finish up with the modern go-to endoscopic treatments. All right, let's jump right in. Section 1. What are we actually talking about when we say GAVE? Okay, so at its core, GAVE is a condition where the tiny blood vessels in the antrum, that's just the lower part of the stomach, right before the small intestine, get all dilated and fragile. And because they're so fragile, they're really prone to bleeding. This can be a slow, chronic leak, causing things like iron-deficiency anemia, or it can be a much more dramatic, acute GI bleed. So let's get practical. You're in the endo suite, you're driving the scope. How do you actually spot this thing? This is where your pattern recognition skills really come into play. You really need to burn two classic images into your brain. The most famous one, of course, is the watermelon stomach. It's called that for a reason. You see these incredible red stripes radiating out from the pylorus. It's unmistakable. The other pattern, which you see more often in patients with cirrhosis, is a more spread out, diffuse pattern, sometimes called a honeycomb stomach. If you see either of these, GAB should be shooting to the top of your differential diagnosis. Now let's say you take a biopsy. There are 4 key things the pathologist is looking for. First, you'll see those dilated capillaries. That's the vascular ectasia. You'll also often find tiny little blood clots inside them, which is focal thrombosis. The other 2 clues are a bit more technical: spindle cell proliferation and fibrohelianosis. But when you put them all together, they make a really strong case for GAVE. Okay, this next part is maybe the single most important clinical pearl in this entire explainer. You have got to be able to tell GAVE apart from its main mimic. So, here's the million-dollar question. You're scoping a patient with known liver disease. You see a red, blotchy-looking stomach. How in the world do you know if you're looking at GAV or if it's portal hypertensive gastropathy or PHG? They can look alike, but they are totally different beasts that need totally different treatments. This table is your cheat sheet. Let's walk through it. First, location, location, location. PHG is usually higher up in the stomach, in the fundus and corpus. GAVE is down low in the antrum. Endoscopically, with PHG, you're looking for more of a mosaic or snakeskin pattern, whereas with GAVE, you have those classic watermelon stripes. But here it is, the absolute game changer, the bottom line. PHG gets better if you lower the patient's portal pressure. GAVE does not. That one fact changes everything. And that quote right there says it all. The reason this distinction is so critical is because the treatments are worlds apart. You might give beta blockers or do a TIPS procedure for PHG, and it could help, but that will do absolutely nothing for a patient with GAVE. Getting the diagnosis right here directly changes how you manage the patient. Okay, so you've diagnosed GAVE. Your job's not done. You have to ask yourself, what else is going on here? Because GAVE rarely shows up alone. It's often a big signpost pointing to another systemic disease. And the connections are pretty striking. A huge number, about 60% of people with GAV have an underlying autoimmune condition, like scleroderma. Another 30% have liver cirrhosis. The last 10% is a mix of other conditions, like chronic kidney disease or a history of bone marrow transplant. So when you find GAV, you need to start thinking about these other possibilities. So what actually causes it? Well, the honest answer is we're not 100% sure yet. It's often described as obscure and multifactorial. There are theories about mechanical stress from the stomach churning, theories about weird hormones, but what we do know for sure is that portal hypertension itself is not the cause. And that, again, is why treatments aimed at lowering it just don't work for GAVE. And that brings us to our final section. We figured out what it is, we know what it's linked to, so what are we going to do about it? Let's talk about the modern approach to treatment.
Luckily, the treatment hierarchy is really clear. First line, hands down, is endoscopic therapy. Medical therapy with pills and things, the role is super limited, pretty much experimental at this point. And surgery, like removing the antrum, that's a last resort, saved only for those really tough cases that fail everything else.
So when we say endoscopic therapy, what are we really talking about? The undisputed gold standard is argon plasma coagulation, or APC. It's a non-contact method that uses a jet of argon gas and an electrical current to basically cauterize and seal off all those superficial leaky blood vessels. And why is APC the go-to? Well, the advantages are just overwhelming. First off, it works really, really well. We're talking efficacy rates up to 90 or 100% in stopping the bleeding. Now, it's a marathon, not a sprint. It often takes a few sessions, but it's also way safer than older laser therapies and definitely safer than surgery. On top of all that, it's easier to use and it's cheaper. It's really the whole package. So here's the bottom line on treatment. APC is your best bet right out of the gate. It's just as effective as a major surgery like an antrectomy, but it comes without all the huge risks, especially for these patients who are often quite fragile, like those with cirrhosis. And this leaves us with a final question to think about. We've seen that GAVE has this very specific local appearance and a very specific local treatment, but we've also seen these powerful links to big systemic diseases. So is GAVE just a localized plumbing problem in the stomach? Or is it really the tip of the iceberg, a visible sign of a much deeper process going on in the body? It's something to keep in mind the next time you see that classic watermelon stomach. Thanks for joining this explainer.